You go to bed feeling perfectly normal. 8 hours later, you wake up and try to get out of bed, but your left arm won't move. You attempt to call for help, but the words come out slurred and incomprehensible. You try to stand, but your left leg collapses beneath you. In the span of a night's sleep, while your conscious mind rested, a catastrophic event unfolded in your brain. This is a wake-up stroke, and it's far more common than most people realize. Approximately 25% of all ischemic strokes, that's 1 in 4, are discovered upon awakening, with the exact timing of onset unknown. These patients go to sleep neurologically intact and wake up with devastating deficits, paralysis, speech loss, vision impairment, or cognitive dysfunction. For decades, these patients were considered ineligible for acute stroke therapies because we couldn't determine when the stroke began, and treatment has strict time windows. But recent advances in neuroimaging and clinical trials have revolutionized how we approach wake-up strokes, offering hope where there was once only helpless observation. Understanding this phenomenon isn't just medically fascinating, it's potentially life-saving information that could prevent permanent disability or death. Let me explain the science behind strokes that happen in your sleep, why they occur, how we now identify and treat them, and what you need to know to protect yourself and your loved ones. A wake-up stroke, clinically termed stroke with unknown time of onset, occurs when a patient goes to sleep without symptoms but wakes with clear neurological deficits indicating acute stroke. The critical problem is temporal uncertainty. We know the stroke happened, but we don't know precisely when. This timing matters enormously because acute stroke treatment is time-dependent. The brain is extraordinarily vulnerable to ischemia, lack of blood flow. Neurons begin dying within minutes of oxygen deprivation. The famous phrase in stroke medicine is, "time is brain." Every minute of untreated stroke results in the loss of approximately 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated nerve fibers. For ischemic stroke, caused by a blood clot blocking cerebral arteries, we have 2 primary acute treatments. Intravenous thrombolysis, administration of tissue plasminogen activator, TPA, a clot-busting medication, within 4.5 hours of symptom onset. This drug dissolves the clot, restoring blood flow and potentially reversing or minimizing damage. Mechanical thrombectomy, interventional procedure where neurointerventionalists thread a catheter through arteries to the brain, physically retrieving the clot. Effective up to 24 hours in selected patients, but most benefit occurs within 6 hours. The challenge with wake-up strokes is that patients typically discover symptoms 6 to 8 hours after last being seen normal, the entire night's sleep. By traditional criteria, they exceeded treatment windows and were denied these therapies, relegated to supportive care and rehabilitation for whatever permanent deficits resulted. But research has revealed something crucial. Not all wake-up strokes occur at sleep onset. Many happen in the early morning hours, just before awakening. Understanding the temporal distribution and pathophysiology of these events has opened new treatment possibilities. The timing of stroke occurrence isn't random. Multiple studies demonstrate circadian patterns in stroke incidence, with peaks during specific periods related to physiological changes during sleep and awakening. Blood pressure variations. Blood pressure follows a circadian rhythm, dipping 10 to 20% during sleep, called nocturnal dipping, and surging in the early morning hours as you transition to wakefulness. This morning blood pressure surge, driven by activation of the sympathetic nervous system and hormonal changes, increases hemodynamic stress on atherosclerotic plaques. Unstable plaques can rupture, triggering clot formation and arterial occlusion. Coagulation system changes. Your blood's clotting tendency varies throughout the day. Platelets, the cells responsible for clot formation, show increased activity in morning hours. Fibrinogen levels, a key clotting protein, peak in the morning. Meanwhile, natural anticoagulant and fibrinolytic systems show reduced activity. This prothrombotic state during sleep and early morning increases stroke risk. Hormonal fluctuations. Cortisol levels surge in the early morning, preparing your body for wakefulness. This cortisol awakening response, while normal, increases blood pressure and affects vascular reactivity. Growth hormone, secreted during deep sleep, also influences cardiovascular function. Dehydration. During sleep, you don't drink water for 6 to 8 hours while continuing to lose fluid through respiration and minimal perspiration. This relative dehydration increases blood viscosity, making it more prone to clotting. Sleep-disordered breathing. Obstructive sleep apnea, affecting approximately 25% of middle-aged adults, causes repeated episodes of oxygen desaturation and blood pressure spikes during sleep. These physiological stresses increase stroke risk substantially. Studies show OSA patients have 2 to 4 times higher stroke risk than those without sleep apnea. Positional effects. Lying flat for hours affects cerebral blood flow patterns. In patients with significant carotid stenosis, arterial narrowing, prolonged supine positioning may compromise blood flow to borderline perfused brain regions. Atrial fibrillation. This common heart rhythm disorder increases stroke risk 5-fold by allowing blood to pool and clot in the heart's atria. AFib episodes often occur during sleep, particularly during REM sleep when autonomic nervous system activity fluctuates. A clot can form in the heart and then dislodge, traveling to the brain and causing embolic stroke. These factors explain why strokes cluster in early morning hours, typically between 6 a.m. and noon, with a secondary smaller peak in evening hours. Wake-up stroke victims discover their symptoms upon attempting to get out of bed or perform morning routines. The specific deficits depend on which brain region is affected. Middle cerebral artery territory, most common, supplies large portions of the frontal, temporal, and parietal lobes. Occlusion causes contralateral hemiparesis, weakness on the opposite side of the body, hemisensory loss, hemianopia, vision loss in half the visual field, and, if the dominant hemisphere is affected, aphasia, language dysfunction. A patient might try to stand and their left leg collapses. They reach for their phone with their left hand, but it won't move. They try to speak, but words are jumbled or completely absent. If they look in the mirror, one side of their face droops. Posterior circulation strokes, affecting the brainstem and cerebellum, these cause dizziness, double vision, difficulty swallowing, incoordination, and potentially devastating outcomes, including locked-in syndrome if the basilar artery is involved. Lacunar strokes, small vessel occlusions causing more limited deficits like pure motor hemiparesis or pure sensory stroke, but still functionally significant. The emotional trauma is profound. You went to sleep in a functional body and woke up imprisoned in a dysfunctional one. Many patients initially think they're still dreaming or having a nightmare, unable to comprehend this sudden transformation. For years, wake-up stroke patients faced a devastating catch-22. They clearly needed acute treatment, but protocols required knowing symptom onset time. Last known well time was when they went to sleep, typically 6 to 8 hours prior, placing them outside treatment windows. The medical community wasn't comfortable giving TPA to patients beyond 4.5 hours because risk of hemorrhagic transformation, bleeding into the damaged brain tissue, increases with time. Treating patients with unknown onset times seemed unjustifiably risky. But 2 landmark clinical trials changed everything: Wake Up and Extend. The Wake Up trial, 2018, researchers used MRI to identify patients likely to benefit from treatment despite unknown onset time. They utilized a technique called DWI flare mismatch. Here's the science. Acute ischemic stroke appears on diffusion-weighted imaging, DWI, within minutes, showing restricted water diffusion in damaged tissue. However, it takes several hours to become visible on FLAIR, fluid-attenuated inversion recovery imaging, which detects vasogenic edema. If a stroke shows up on DWI, but not on FLAIR, it's likely less than 4.5 hours old. This imaging signature identifies a potentially treatable window. The trial randomized wake-up stroke patients with DWI flare mismatch to receive TPA or placebo. Results were striking. Patients receiving TPA had significantly better functional outcomes at 90 days with no increase in symptomatic hemorrhage. The Extend trial, 2019, used CT or MRI perfusion imaging to identify salvageable brain tissue in patients 4.5 to 9 hours from symptom onset or with wake-up strokes. Perfusion imaging shows areas with critically reduced blood flow but not yet infarcted, the ischemic penumbra that can be saved if blood flow is restored quickly. Patients with significant penumbra received TPA with excellent results, better functional outcomes, and more frequent excellent recoveries compared to placebo. These trials proved that imaging-based selection allows safe, effective treatment of wake-up strokes. The key is identifying patients whose brains are still salvageable despite unknown timing. Modern stroke centers now have protocols for wake-up stroke patients: emergency evaluation, immediate non-contrast CT scan to exclude hemorrhage, then advanced imaging with either MRI showing DWI flare mismatch or CT perfusion or MRI perfusion showing salvageable penumbra. Thrombosis. If imaging criteria are met, administer IV TPA even with unknown onset time. This has become standard of care based on trial evidence. Thrombectomy. For large vessel occlusions, mechanical clot retrieval is performed up to 24 hours from last known well if perfusion imaging shows favorable patterns. Wake-up stroke patients with large vessel occlusions are increasingly receiving thrombectomy with excellent results. Comprehensive stroke care. Blood pressure management, glucose control, temperature regulation, swallowing assessment to prevent aspiration, early mobilization, and immediate initiation of secondary prevention. Secondary prevention, identifying and treating stroke causes to prevent recurrence. Antiplatelet agents, aspirin, clopidogrel for atherosclerotic strokes. Anticoagulation for cardioembolic strokes, especially atrial fibrillation. Statins for cholesterol management, blood pressure control, diabetes management, lifestyle modifications, sleep apnea screening. Given the strong association, stroke patients should be screened for OSA and treated with CPAP if present. Time remains critical. Even with these advanced protocols, earlier arrival to the hospital improves outcomes. That's why recognizing symptoms immediately upon awakening is vital. Remember the acronym B FAST. B, balance, sudden loss of balance or coordination. E, eyes, sudden vision loss or double vision. F, face, facial drooping, uneven smile. A, arms, arm weakness, drift when raised. S, speech, slurred speech, inability to speak or understand. T, time to call 911 immediately. If you wake up with any of these symptoms or discover a family member or roommate with these signs, call emergency services immediately. Do not wait to see if symptoms improve. Do not drive yourself to the hospital. Do not delay to shower, eat, or take medications. Every minute counts. Paramedics can alert the hospital en route, allowing the stroke team to prepare. You'll receive imaging and treatment faster than if you drive yourself. Importantly, stroke doesn't hurt. Many people delay seeking help because they don't feel pain. Brain tissue has no pain receptors. The absence of pain does not mean absence of emergency. Understanding risk factors allows targeted prevention. Non-modifiable. Age, risk doubles each decade after 55. Sex, slightly higher in men before 75, higher in women after. Race, higher in Black, Hispanic, and Native American populations. Family history, previous stroke or TIA, modifiable. Hypertension, single biggest risk factor. Atrial fibrillation, especially undertreated. Diabetes mellitus, high cholesterol. Smoking, double stroke risk. Obesity, physical inactivity. Poor diet, excessive alcohol, sleep apnea, often undiagnosed, carotid artery stenosis. Prevention strategies: regular blood pressure monitoring and treatment, AFib screening, especially in those over 65, diabetes control with A1C under 7%, statin therapy for appropriate patients, smoking cessation, Mediterranean-style diet rich in vegetables, fruits, whole grains, fish, olive oil, regular physical activity, 150 minutes moderate intensity weekly, maintaining healthy weight, limiting alcohol to moderate levels, sleep apnea evaluation and CPAP therapy if diagnosed, aspirin in selected high-risk patients, discuss with your doctor. For those with significant carotid stenosis, over 70% narrowing, carotid endarterectomy or stenting can prevent stroke. Myth 1. Strokes only happen to elderly people. Reality, while risk increases with age, strokes occur across all ages. Approximately 10% of strokes occur in people under 45. Risk factors like obesity, diabetes, and sleep apnea are increasingly affecting younger populations. Myth 2. If symptoms are mild or transient, it's not serious. Reality, TIA, transient ischemic attack, where symptoms resolve within 24 hours, is a medical emergency and major stroke warning. 15% of stroke patients had a preceding TIA. Many wake-up strokes begin as TIAs during sleep that progress. Myth 3. Stroke treatment is futile. You'll be disabled anyway. Reality. Modern treatment dramatically improves outcomes. Patients receiving TPA within 3 hours are 30% more likely to have minimal or no disability at 3 months. Thrombectomy can produce near-complete recovery in large vessel occlusions when performed quickly. Myth 4. If I wake up with symptoms, it's too late for treatment. Reality, the trials prove this false. With appropriate imaging, many wake-up stroke patients can receive effective treatment. Never assume you're beyond the window. Go to the hospital immediately. Myth 5. Taking aspirin during a stroke will help. Reality, do not take aspirin if you think you're having a stroke. You don't know if it's ischemic, clot, or hemorrhagic, bleeding. Aspirin with brain hemorrhage is catastrophic. Call 911 and let the hospital determine the type and appropriate treatment. Wake-up strokes carry unique psychological burden beyond typical strokes. Patients experience profound loss of control. The event occurred while they were completely vulnerable and unconscious. Many develop anxiety about sleep, fearing another event. Sleep anxiety after wake-up stroke is common. Patients lie awake, hypervigilant to bodily sensations, terrified of losing consciousness. This fear-based insomnia creates a vicious cycle, worsening cardiovascular risk factors. Survivors need comprehensive rehabilitation, physical therapy for motor deficits, speech therapy for aphasia, occupational therapy for daily living skills, and psychological counseling for adjustment and anxiety. Family dynamics change dramatically. Spouses often develop hypervigilance, waking repeatedly to check on their partner. Some couples sleep separately so the well spouse can rest. The stroke survivor may feel guilt for this burden. Support groups help immensely. Connecting with other survivors normalizes experiences and provides practical coping strategies. Many find purpose in stroke awareness advocacy, turning tragedy into mission. Myth 5. Research continues advancing. Extended time windows. Studies are exploring thrombectomy beyond 24 hours in highly selected patients with favorable imaging. Neuroprotective agents. Medications that protect brain tissue during ischemia could extend treatment windows and improve outcomes. Mobile stroke units. Specially equipped ambulances with CT scanners and telemedicine stroke neurologists, allowing treatment initiation before hospital arrival. Some cities deploy these for wake-up strokes. Artificial intelligence. Machine learning algorithms analyzing imaging can rapidly identify strokes and predict which patients will benefit most from treatment, accelerating decision-making. Home monitoring. Wearable devices detecting atrial fibrillation or other stroke risk markers could enable preventive interventions. Tenecteplase, a newer thrombolytic easier to administer than TPA, showing similar efficacy with simpler dosing. The goal is simple: save more brain tissue, reduce disability, restore function. Wake-up strokes represent one of medicine's most challenging scenarios. Catastrophic events occurring in darkness, without witnesses, without warning, yet demanding immediate action despite temporal uncertainty. For decades, these patients faced nihilistic outcomes, their timing of injury excluding them from therapies that might have saved their function. But science evolved. Advanced imaging revealed that brains tell their own story through patterns visible on DWI, FLAIR, and perfusion sequences. Clinical trials proved that selecting patients based on tissue viability rather than clot time allows safe, effective treatment. Today, a wake-up stroke patient arriving quickly at a comprehensive stroke center has real hope for recovery. But this hope depends on recognition and action. You must know the signs. You must call 911 immediately. You must advocate for yourself or loved ones. The brain you save may be your own. The person you rescue from permanent disability may be your spouse, parent, sibling, or friend. Knowledge is power, but only if transformed into action. Tonight, before you sleep, consider: do you know stroke signs? Does your family? Do you have modifiable risk factors you're ignoring? Is your blood pressure controlled? Have you been screened for atrial fibrillation? Is your sleep apnea treated? These aren't abstract medical questions. There's life or death considerations that could determine whether you wake up tomorrow in your body or imprisoned within it. Time is brain. Recognition is survival. Action is recovery. Don't let your brain suffer in silence while you sleep.